Hi, Brittany. Thanks for your insightful CHNA interpretation of DeSoto, where you emphasize how intertwined issues like financial instability, housing, transportation, and provider shortages deepen depression. I compared DeSoto to Rockingham, and in Rockingham County, North Carolina, I found similar concerns. Depression and substance misuse are prominent issues, strongly rooted in lack of access to care, poverty, and housing insecurity. Transportation is also a barrier here, just as it is in DeSoto. Provider shortages delay treatment, which often worsens symptoms before people seek help. In 2020, in a 2023 systematic review by Edwards et al., they found that rural patients in North America often experience worse access to care and higher suicide risk compared to urban patients. These disparities are primarily attributed to limited access to resources, travel burdens, and high service costs. Their results were mixed, with some studies showing no disparities or even better treatment adherence in rural populations. Furthermore, Hung et al. 2025 reported that over 40% of small and isolated rural zip code areas over 30 minutes from any mental health facility, more than 4 times the rate of urban areas, 9.4%. These communities also face digital divide issues, limiting telehealth access, which compounds the urgency of early coordinated intervention. Together, these studies reinforce that both DeSoto and Rockingham County suffer from access barriers, socioeconomic stressors, and limited infrastructure, requiring a robust, integrated response from clinical, community, and faith-based systems. I fully agree that the Christian community is essential in improving mental health outcomes. Churches offer trusted environments that can reduce stigma, educate, and foster connection. Ling and Liu 2023 piloted a faith-based intervention involving 6 weekly sessions on themes like hope, forgiveness, and gratitude. They saw significant decreases in PHQ-9 depression scores, sustained at 3 months, alongside improved coping and self-esteem. This underscores the power of structured, spiritually informed group interventions. One additional strategy I would recommend is integrating mental health professionals into primary care settings. Embedding behavioral health clinicians with clinics makes care more accessible, coordinated, and less stigmatizing. Research supports this approach. Shillock et al. 2025 conducted a meta-analysis in JAMA Psychiatry and found that collaborative care models in primary care significantly reduce depressive symptoms compared to usual care. Combining this integration with church-led outreach could create a dual support network consisting of faith-based engagement plus clinical care. Thanks again for sharing your insights. I'd love to hear your thoughts on pairing integrated clinical care with faith-based applications. In other words, how might these strategies strengthen DeSoto's response to depression?